next presentation is again by Rebecca.
Yes.
She will show.
Could you put me the
her-
clock, please?
Her experience.
Yes. Because if you give me a few minutes more, I will take it. No, but it's fine. I'm going to talk about the endovascular management of acute PE, percutaneous thrombectomy versus fibrinolysis. So I have no disclosures. This is a clinical case. It's a woman, 84 years old. The background is only vascular dementia. 1 week before the present emergency consult, she was interned into the hospital because she has a urinary infection. She undergoes with antibiotics. She goes to the ER with a swollen right arm with cyanosis, and the family doesn't know what time of evolution. She has vascular dementia, but she lives alone. So the family has some web camera, and they are seeing her. So the days that they didn't see her on the camera, so because they don't live there in San Luis, they live out of San Luis, they travel to San Luis to see what happens. So she's seen by a geriatric doctor and diagnosis with cellulitis, like it was an infection, and she was, because she has pulses in the arm. That is the note of the emergency room. So she stayed at the emergency room, and the emergency doctor see that increase of the swollen right arm and the cyanosis, and she, so he asked for a Doppler ultrasound, and he called me. So, like you can see, there is a total thrombus of the subclavian vein. So, always that I have a thrombus in the arms, I have always to see a CT scan, because I have very bad experience with the thrombus that are not only on the arm, they are inside the thorax. And like you can see in both of the CT scans, I have a huge and severe PE. And it was not only a PE, she has thrombus in the subclavian and the humeral and the axillary vein. So we performed after this incidental that we see that the PE, we make an echocardiogram, and he has, hypertension, pulmonary hypertension. So the technique for me this time, it was a venous ultrasound, and it has, like I told you, chronic thrombus of both superficial and femoral veins in the legs. And she has thrombosis in the right humeral, axillary, and subclavian vein. So I'm a vascular surgeon, so I perform all my ultrasounds, even that it takes a lot of time. So the ultrasound, I made a punction, echo guide punction from a femoral vein on the right side, and we cannulate both pulmonary arteries. We see a massive PE. Let me see you. The technique was a pulmonary angiography, and you can see that we have a severe PE. So at this time, it was very late at night. Besides that, the patient was the mother of 2 doctors that we know. My equipment know the 2 daughters. So what we can do with this kind of thrombus that we don't know exactly what happens with her? The options in Mexico, like I told you, we have thrombolysis, like you can see that I perform a lot of thrombolysis. Like we can do it systemic, we can do it by catheter. That in that time, when she arrived, the company that managed echoes, they didn't have the catheters for, I guess, like 10 months or almost 1 year. So we couldn't do it that. So we have the McNamara catheters that are thrombolysis. You know, it's a catheter that has little or small holes. And we have thromboaspirations. with the penumbra catheter, the new one, and we have angiojet, like I said, the Omni or the Celente catheter, or nowadays we have the INRE, that is the newest that arrives to Mexico. So we perform the Celente catheter. So we try to do it easy. We try to do it, you know, we only perform all the treatments with an anesthesiologist for everything we needed. And in this time, like we were manage a lot pressure inside the pulmonary arteries. We have a lot of issues with the heart, with the rhythm of the heart, with the pressure of the patient. So we try to do it the best we can, and we have a lot of time inside the room. So we didn't have the result that we were expecting. So we decided that we were going to perform something else. Like we don't know the time of the thrombus, we decided not to do thrombolysis at that time. And we started using the INRE system, that is the flow trigger in this case, like we can see in the second image. I'm going to show you how is the INRE system working. Sometimes they have thromboaspiration, and they have, besides thromboaspiration, they have like three different, like there were three different filters, so you can catch the thrombus and you can take it out. Let me see. Okay. This was the first time that we use it. And the first time that we use it, we have a better result, but it was not like we expected. This is the video that show us how it acts. It has a syringe that you can aspirate the thrombus with the blood. But the good result, this is the kind of blood trigger that we have. There is like three different filters, so they can remove almost all the clot. And the important thing of this is that when you aspirate the thrombus with the blood, it has another filter inside the syringe, so you can put it again to the patient. So it's a good, for me, it's a good result that you are not taking all the blood out. You can put it inside the patient again. So we perform the INRE system many times. So like you can see, we have a better result, but it was not enough. So we put the patient, because she's old and we have some heart issues, we have to stop the procedure there, even that we have a very good result, but not as we wanted. We tried to canalize the subclavian vein. Let me see. This is from the bottom of the lung that we tried to make the thrombectomy. So during the procedure, we improved the oxygenation, but not her blood pressure. So she requires a means. We know that she was going to pass to the ICU. We treat to see what is going to happen with the arm, and we canalize the humeral vein, and we made an angioplasty there, but it was not successful, so we just left her into anticoagulation. So this one is the last that the last angiogram, pulmonary angiogram that we have. So we improved it, but we didn't have the best result. Like you can see, this is the thrombus that we take, so we realized that it was not new, it was very old, the thrombus, but at least we did something for her. She improved it. At the end, at the month, she died because of the heart failure. But at this time, the patient goes better. So my conclusion is, in this particular case, thrombolysis could be a good option. I don't know, what do you think? And if you performance a different treatment or combined procedures, and if there is no better thrombolysis versus thrombectomy procedures, depends on the findings, the patients, the time, and the available technique. So be open to learn. I always say that new techniques, you may need it once or maybe many times. So now I'm going to invite to all the people who speak Spanish to the convention in Washington, to the CBHH, that is a Convención Internacional of Vascular Spanish Convention. Thank you.